The purpose of the Dizziness Diagnostic tool is to provide a point-of-care resource for clinicians diagnosing dizzy patients. Dizziness is the third most common symptom of patients presenting to general medical clinics. Acute vestibular syndrome is one type of dizziness characterized by a sudden onset. It persists for a day or more and is accompanied by nausea or vomiting, poor balance, and intolerance to head motion. Each year, 500,000 people in the U.S. present to the emergency room with acute vestibular syndrome. It is most often caused by a viral infection, in which case it is not dangerous. However, roughly 25% of strokes, a much more dangerous cause, can look exactly like such a viral infection. As a result, just under half of these strokes are initially missed by clinicians, putting 20,000 patients a year at significant risk for disability and death. Physicians need tools to help sort out when dizziness requires more careful follow-up and when patients can be sent home. That is where the Dizziness Diagnostic tool can help. The diagnostic tool guides physicians through the relevant parts of the patient history and physical exam, and uses Bayesian statistics to calculate how probable it is that the patient had a stroke based on the collected data. The tool begins by reminding the care provider what acute vestibular syndrome looks like. When the provider clicks Continue, he or she is then presented with the main interface. The header bar provides information about the patient, including name and age. Below the header, there are two big boxes corresponding to information about the patient's medical history and information about the patient's physical exam findings. Each of them contains a prediction of the probability that stroke is a cause of the patient's dizziness, indicated by the large number at the top of each box. For the past medical history box, data is retrieved from the record to figure out which of the stroke risk factors the patient has. Under the hood, stroke prevalence data and Bayesian likelihood ratios calculated from previous literature are used to estimate a pretest probability that the patient has had a stroke. Providers can review what diagnoses from the patient's problem list have been selected and adjust them accordingly. For example, if a provider decides here that this patient's previous smoking problem and depression are not really active issues, he can unselect those parts of the history. The provider then moves on to the physical exam box. There are three sections corresponding to each of the exam maneuvers. For each maneuver, the provider can choose to read information about it by selecting the Info button. They may also watch videos for examples of each of the findings. As the provider enters the results of each exam finding, the tool uses this to estimate the probability of stroke using Bayesian likelihood statistics. Providers can then use the final result to determine if it is safe to send patients home, or if they will be required to stay in the hospital for further evaluation. Here, the patient's high probability of having had a stroke warrants further workup. It is our hope that such a tool may aid in diagnosis and improve outcomes among patients presenting with this common problem.